I want to thank Dr. Alun Davies for agreeing for this podcast. Dr. Alun Davies has been one of the worldwide leaders, not only in venous disease, but in vascular surgery and medicine. His CV goes on for 116 pages with contributions to all aspects of our field. He is a great clinician, researcher, scholar, educator, mentor, and leader, and his influence has been felt worldwide. He's authored over 580 publications, many of which have pushed the field forward. So thank you, Dr. Alun Davies.
It's a pleasure.
So I want to focus a little bit on venous stasis ulcers. Your past, present, and work has really been helped set the standard of care. Where has your present work, based upon your past work, been taking you in terms of venous stasis ulcers?
Well, where we're very much at is, as you know, the Everett trial came out and showed very clearly that intervening on superficial veins reduced the amount of time that an ulcer was present, i.e. improved healing rates, reduced recurrence rates, and was undoubtedly cost effective. This is now obviously very much now in the implementation phase worldwide, trying to get people to buy into the concept of like a 2-week pathway for the management of these patients. And we are slowly but surely beginning to see that happen. However, there are many other questions that arise about the venous leg ulcer population. What's the importance of the subdermal plexus? What's the importance of the iliac system? And should we always be imaging for these? And we're working on those. We're also looking at, should somebody with a venous leg ulcer be taking a medication? There are various medications around, such as pentoxifylline. Are statins of any benefit? We're beginning to look at that. And we're also looking at as to whether people who have heel leg ulcers should actually routinely have duplex imaging, and if any incompetence is found, should that be treated again to minimize the amount of recurrence? So that gives you an idea and a flavor for where we may be going with some of the future research. We have been very fortunate in being selected by our government and our NIHR to put in a preliminary bid on a vein platform trial that we have put in a bid for around about 10 or 11 million to run a platform trial similar to the COVID platform trials. So we're very much keeping our fingers crossed at the moment to see if that will come to fruition.
So you point out that the nursing component for care of these patients can be important, and timely care can be important, especially with referrals to venous specialists. How do you push the ball forward for these two components in terms of timely referrals and the multidisciplinary care that's required for these patients?
Well, in the UK, we've actually managed to get our government on side, and we now have something called a sequin, where people who initially see the patients, usually in what we call primary care or the community, have been set a target that they have to have been referred and seen within 2 weeks of presentation to primary or secondary, primary or community care. And this is called a sequin. And basically, sequins work with either paying somebody a bit more money, or if they don't meet the target, taking some of the money away. A similar thing in parallel to how some hospitals in the United States managed to get people to perform with respect to VTE risk assessments and various things. So there's a big national push, certainly in the UK, to actually get these patients seen earlier. And actually, by having this very much propagated to primary or community care, is actually pushing people towards being assessed by, in the UK, basically all venous disease is treated by vascular surgeons. And we don't, like in other parts of the world, have really phlebologists or other disciplines. So it's very much all comes under the vascular umbrella.
One component that we've had problems with here in South Brooklyn is patient compliance. How do you deal with some of that, especially with the elderly patient who's leg is constantly dependent and you close the veins, you look at the iliac veins, you put them in compression, and the home issues, the social issues, and the compliant issues, there's still a significant problem. How do you suggest working around some of these issues?
Well, I think it's actually very difficult, and I don't think anybody has got to the right answer to actually enhancing compliance. I think you have to sort of get the patient engaged as to what is actually going to work for them. Now, for example, if you go and tell them that they've got to wear stockings that are class 3 tight stockings, you know that that's never ever going to work, and you may have to accept that they wear a type 1 stocking, or that they are going to use wraps which are easier to put on with Velcro. So I think you have to modify what you can do. I think the one bit that we're not very good at is actually trying to get these people involved in exercise stroke rehabilitation classes, which actually, if you can get these people to actually go and do a little bit more walking and everything else. And I think there are often a cohort of patients who are quite isolated. And we've certainly seen from other exercise programs that actually it's actually the collegiate atmosphere of all these people getting together improves their healthcare more than anything else. So I think it's a underfunded, under-resourced, and we don't really quite know how to do it very well.
Your work with your team has been stellar for decades. What suggestions would you have for early career investigators who are interested in starting to do research in terms of outcomes, in terms of these difficult issues?
I think the key thing is to find a subject that interests you, that you want to do it in. And yes, I think the answer then is to try and find a mentor who can actually take you through all of the processes, being it from, yes, is it a reasonable question, putting ethics applications, grant applications, and helping you go through the process. And I think it's like anything, start small, you learn some of the techniques, and then you go higher and higher with respect to where you get funding from. But I think the key thing is try and find yourself a mentor who can mentor you through the process, and be prepared to be completely humble and put your hands up and say, I really don't know anything about this. Can you help me to do it? Because we all have to do that, because there are lots of things that none of us know, but we often might know a friend who might be able to help us do various things.
So along the way, you had chaired the NICE guidelines for varicose veins in 2013. Is there an update coming up?
No, we've had it. We had an update at 5 years that we felt there wasn't going to be any change. We have and I've just completed it. There's an NHS prioritization for lots of different procedures, and I've just done it for the varicose veins, VTE, and abdominal aortic aneurysms. And there really are no fundamental changes, I think, going to be present for the varicose vein one, because the referral guidance, which has also become, is that you should refer anybody with symptomatic varicose veins, be they primary or recurrent, still stands. We've approved all of the newer non-thermal techniques as being standard of care. So they fit into the same category as radiofrequency or laser. So there isn't really a lot to change in it, because there hasn't been any, should we say, earth-shattering changes in how we manage superficial venous disease.
I want to thank you so much. You've covered so many different topics and really have some great pearls of wisdom from decades of experience. And we're looking forward to some of your upcoming research in this field also. So again, thank you so much.
Been a great pleasure. Thank you.